a high caliber group of people that's speaking today, so thank you. So again, my name is Jessica Faainuinu. I work at Castle Adventist Health. I've been a nurse for 15 years and currently in the ICU for the last 8 years. So why ABCDEF bundle? Anyone, show of hands, have heard of the ABCDEF bundle? Okay. As a show of hands too, just so I can understand the group. Nurses, anybody? Oh, we got one. Okay, so I apologize. This is probably going to be a lot of boring information for you respiratory therapists and physicians. So bear with me. Feel free to take another break or get some food and not pay attention. I'm fine with that too. So it is a quality improvement process since 2013 that was developed and emerged from the guidelines from the Society of Critical Care Medicine. And it's a process for interprofessional teams to work together to achieve positive outcomes for patients on ventilators. And then the guidelines were updated back in 2018. And it continues to be the driving force and the reference standard. So today I'm going to go through the objectives of defining each component of the bundle, defining the disciplines involved in the process, barriers to the bundle implementation, and positive outcomes from process implementation. So it's an ABCDEF bundle, so of course nurses like their acronyms. So A stands for assessment. So we first assess the patient, why the patient is on the ventilator. Are they, is it a disease process that we're treating, or is it procedural? So we look at the diagnosis and the goals of therapy. So we want to improve the oxygenation, boost ventilation, permit sedation to properly ventilate them, and reverse respiratory muscle fatigue. We also look at their response to therapy. Are we doing changes to treat the patient fully and completely to get them off the ventilator? We want to assess and prevent pain management. So we look at the CPOT score. So nurses probably know this, but I'm not sure if respiratory therapists and physicians know, but it's the critical care pain observation tool that we utilize to assess the pain level of the patient while they're ventilated and sedated. So pharmacologic, we treat the pain with pharmacologic methods. Either fentanyl, morphine is commonly used. And then we can also look at non-pharmacologic treatments, music therapy, getting the family involved, hand holding, things like that. We also want to assess and prevent infection. So we use the VAP bundle, and that includes, which I'll show a slide later that has a picture that indicates all the components of the VAP bundle. But basically you're doing your oral care, your head of bed 30 degrees, utilizing a PPI, doing your sedation vacation Q shift, and then incorporating your DVT prophylaxis, all incorporated in the VAP bundle. And then the VAP, obviously, probably most of you know, the ventilator-associated pneumonia. So you're doing all those things to prevent pneumonia. Your prophylactic antibiotics, and that can be a significant impact on decreasing respiratory infections and decreasing mortality. Equipment, you have your patient come in from through EMS and they have a intubated in the field. Depending on your ET tube size, you might want to exchange that ET tube because most field start ET tubes don't have a subglottic suction. So a lot of times if there's a lot of secretions, to prevent infection of the and secretions being unable to get out through the ET tube, you would switch out your ET tube so you have a subglottic section. And then obviously proper nutrition. Without proper nutrition, the patient can't heal, and you either administer your nutrition via the OG tube through parental nutrition, or if they have to, TPN. And usually you start nutrition within 24 to 48 hours. So this is a the CPOT tool, and we utilize it and for the nurses, and we look at facial expression, body movements, muscle tension, vent compliance, and vocalization. And these are the components that we utilize and assess every shift. Actually, for our protocol, when patients are ventilators, we're looking at the CPOT score every 2 hours. And then obviously their level of sedation can affect the way that you would do their assessment. And the key to this is obviously if their pain score is high, you want to make sure to manage and treat their pain. And this is the image of all the components of the VAP bundle, excuse me. Again, the oral care every 2. It does say on here with chlorhexidine, which I did see according to the critical care nurse article in 2024, that the use of CHG is non-significant. So some physicians have a preference to utilizing it, others don't. The key is that the oral care is actually being done every 2 hours. So B, as part of the ABCDEF bundle, is the breathing trials. So your spontaneous awakening trial, we do daily. I did hear some conversations about the timing of the spontaneous awakening trial. We typically tend to do them in the mornings. The big key is that we as nurses like to do them when our physicians are present, because then obviously if your spontaneous awakening trial goes well, then you would progress to a breathing trial and possibly extubation. So we do that as long as the physician is in-house. Our inclusion criteria is that they're on sedation and they've been on the vent for at least 12 hours. Their exclusion criteria would be if they're having active seizures, they're active DTs, or they're having vent dysynchrony. If you're having to escalate doses of sedation, they're on a paralytic medication for neuromuscular blockade. They've had an NSTEMI in the last 24 hours, or they have increased evidence of ICP or increased intracranial pressure, or on TTM therapy. So you look at those inclusion exclusion criteria, you go ahead and do your pass-fail, and if they then if RN proceeding with the SBT, with their respiratory therapist to proceed with that SBT. If they fail, that would be an indication if they're agitated, they're desaturating, they become hemodynamically unstable, they're having arrhythmias, then you would restart the dose at half. So then you can reassess the next day or the next shift. So then if they do pass and then proceed to the SBT, the pre-SBT, you would look if they have a cough, a gag, secretions are well managed, and they're hemodynamically stable and their vent settings are minimal, then you would proceed to doing the SBT. That was your criteria prior to SBT. And then your pass-fail criteria, pass if they have no mental status changes, they're hemodynamically stable, their tidal volume is greater than 300, and they're having spontaneous breaths, which keeps their saturations over than 88%. If they fail, then they would have abrupt mental changes, unstable arrhythmias, tidal volumes less than 300, and their saturations are less than 88%. And then if they fail, then weaning trial, you have to consider either prolonging it, again, kind of back to Kimmy's prolonged weaning, the prolonged weaning trial. And then if you are unstable, you would have to just reassess daily, follow obviously your facility protocol. And then if you're unable to wean, that would be kind of the conversations you would have to consider having them go to a trach, or if it's a patient that's on palliative, doing end-of-life conversations and goals of care conversations with the family. And this is just kind of a algorithm that we would usually follow for their SAT and SBT, their inclusion and exclusion criteria, and their pass-fail. So in C is your choice of sedation. So again, we assess the patient and their diagnosis, some of the contraindications for different medications. Obviously, you look at their allergies. If they have high triglycerides, there's something to consider. There's a propofol infusion syndrome, which is rare, but then it can occur if the patient's been on propofol over 24 hours. and can cause metabolic acidosis, hyperkalemia, hyperlipidemia, rhabdo, and could lead to cardiac and renal failure. You're looking at the hemodynamics of the patient, effects on their heart rate, their blood pressure, and you may need to add vasoactive support if it causes low blood pressure. And obviously, you're looking at the patient's tolerance to the sedation. If they're ETOH or a drug abuse patient, they have a higher tolerance, so your doses might be higher than others who aren't. And you want to maintain a RAS score of -2 for those patients, which may require higher doses. You're looking at their pain and anxiety levels. So obviously you want to control their pain and anxiety to prevent any risk for self-extubation and prevent vent dysynchrony as well. So the medications, as you can see in my friend's picture, the anesthetics that we use, you could be on propofol or Precedex. Precedex is one that's commonly used if we're trying to extubate, but they're not quite staying calm enough. They're still agitated because we still can wean them, have them kind of in a awake state and still extubate while on Precedex. But propofol is the most commonly used one. Your analgesics, you have fentanyl, morphine, which are commonly used. The opioid use can reduce the respiratory drive, so you have to be careful on the amount and the doses that you're using, and it can cause vent dysynchrony as well. Anxiolytics, you definitely want to look at if you need PRN Ativan or PRN Versed sometimes is used as well, although being careful to avoid increased mortality on patients compared to propofol. So your propofol and your Precedex are most common. Paralytics, obviously, if you get up to ARDS and you're proning the patient, then you have them on a paralytic such as Nimbex or PRN Rock. Our RAS goals obviously are to have that -2, which is they're comfortable, they have vent synchrony, and they're able to somewhat open their eyes. When you're on a breathing trial, you lighten the sedation, so you have them more calm, awake, and alert, but not thrashing. So this is kind of our Richmond agitation sedation scale that we use. And the goal, like I mentioned, is 0 to -2. D, as part of your ABCD, is delirium. So, sorry. To assess delirium, we have to use the CAM ICU, and we assess this every shift. And we want to stop and consider and review what medications they're on and kind of create a plan to reduce the drug exposure. So there's an acronym, again, nurses like acronyms, called THINK, to identify the cause. So when you think, you're identifying the cause is the first step of delirium management. So T would be your toxic substances, or excuse me, toxic situations. So are they in CHF, shock, dehydration? Do you have other medications that can cause delirium, or new organ failure such as a liver or kidney? H would be your hypoxemia. I would be your infection, sepsis. N would be your non-pharmacological interventions neglected. So is the patient requiring hearing aids or glasses or sleep protocol, noise control? Is that affecting their mentation and causing them to go into delirium as well? And then K would be your potassium or electrolyte problems. We want to prevent delirium by performing your daily sedation awakening trial. And like I mentioned, if they're unable to wean, you kind of decrease the dose of your sedation at half to minimize the delirium state. Orientation and reorientation, you're constantly communicating with your patient, having family involvement to reorient them as well. Promote quality sleep, maintaining your day and night lighting even can affect patient delirium. Clustering care as far as nurses with your turns, your oral care, your med pass, kind of clustering that to promote their sleep environment. and family collaboration. Like I mentioned, having the family bedside, communicating with them to help reorient them, sometimes putting up photos just so that they are able to reorient themselves if their eyes open. Managing delirium, we can use their sleep aids. So maintaining their sleep routine, adding the melatonin at night if that helps, or if they have a sleep protocol that they already use at home, reinitiating those medications that they use at home. Speaking of medications, we have Haldol is atypical antipsychotic, or we use Seroquel often as an off-label use. Technically, there is no drug FDA-approved medication to treat delirium in children or adults, but we use these kind of as an off-label that does help with the delirium management. And non-pharmacological would be avoid your malnutrition, avoid use of restraints, although I know we like to have restraints, and obviously if it's needed, it's, you know, to avoid them self-extubating, then we have to, but if you can avoid use of restraints, that is helpful as well. Remove all tubes and equipment that's not necessary. Keep a calm environment, treat the pain, provide cognitive stimulation and mobilization. So this is our CAM ICU flow sheet, and you're assessing their acute change and fluctuation, and depending on your questions or your answers to the question, you would follow the algorithm either to yes or no. And then their inattention, if they're able to follow the commands of squeezing your hand when the letters A is said, and then you're assessing their level of consciousness, and then assessing their disorganized thinking. And based on this is how you would score their level of delirium. So E in the bundle is early mobility and exercise. So obviously assess whether or not the safety screening is performed. If you perform this daily, and you have to assess whether or not the patient is appropriate for it. They're able to follow commands, they're calm, they're not gonna pull their tubes out. This picture alone gives me anxiety because I've never actually had a patient who has an ET tube that's up and walking this well. We've done it with patients on trachs and trach collar, but some facilities do push the early mobility, even with the ET tube. And obviously it takes many hands to do this, but clearly some facilities have done it, so it's possible. There's an article based on the Critical Care Nurse magazine that initiated this Just Keep Moving. So again, another acronym, screen for safety. Oh, excuse me. So MOVIN, M stands for your myocardial stability. So they have no cardiac ischemia in the last 24 hours, no dysrhythmias, and no new agents to control their cardiac state. O, oxygenation stability. So their FiO2 is at a safe level, your PEEP is less than 10, and your airway is secured. Vasopressor use. You have either no vasopressors or no increase in vasopressor use for 24 hours. Engages to voice. So they're following verbal commands, and their RAS is calm and alert. And neural stability, there's no increased ICP and no acute or uncontrolled intracranial event. So absolute contraindications, obviously, if you're on a paralytic, their hemodynamic instability, unstable fractures, uncontrolled ICP, active bleeding, or they have devices such as a balloon pump, Impella, CRT, or ECMO would be a contraindication. It's a multidisciplinary approach. So obviously many hands make for less work. So you have to have the communication and coordination with the RN, the PT, OT, RTs, and then obviously your techs and aides if needed. I'll show you on a different slide kind of the different scales or tools that we use to assess their level of mobility. So benefits to therapy and getting early mobility is their increased gas exchange, mobilized secretions, increased range of motion. It decreases your DVTs and decreases pressure injuries, excuse me. So this is the progressive mobility continuum tool that we use at Castle. And it's a lot of words, but basically you look at the goals, and depending on your goal, and where you're at in your goal, then you would rate them and chart in your documentation a level A, B, C, D, or E. And then the American Critical Care Nurse, AACN, also created a kind of more simple mobility tool that we can chart either a level 1 through level 4. So F in the bundle is family engagement and empowerment. So communication, when we communicate with the family and the patient, we have to be respectful, responsive, and be sensitive to their needs and their values and their cultural beliefs. We want our communication to be patient-centered. So use simple words, be concrete, take your time, remind patient of the time of day to reorient, talk to about family and friends so they can have kind of that positive environment and hope, I guess, in recovery. Provide hearing aids and glasses that helps with the delirium. And then you can utilize decorating the room with different things to help orientation as well. Keep the patient and family informed. Utilize the case managers, having the physicians talk directly to the families, and utilizing the case managers if you need to coordinate a family meeting. Education, explain procedures in layman's terms. So making sure you're communicating with them on terms that they can understand. Explain the purpose and the goals for care being done, and provide resources and educational materials as needed. Collaboration with the family, you want to include all your multidisciplines, so your physician, your case manager, social worker, and chaplain as needed if you have those available at your facility. Goals of care discussions can be difficult, so having all those disciplines involved in the conversations and having the family be actively involved in the conversation is helpful. And then obviously having them participate in the care. So the mobility, I personally have asked family a lot to help with range of motion. So even though the patient's on the ventilator, sometimes they're afraid to like touch the patient. And I say, no, you can participate in their care. You can move their arms, move their legs. This is all helpful while they're being on the ventilator. So obviously all of the bundle, A through F, is a multidisciplinary approach. So it incorporates all these disciplines. I don't think I missed anything or anyone. Let me know if I did. But it is definitely a teamwork effort, and teamwork is key. Some of the barriers to the bundle. Knowledge deficit, it can lead to inconsistent, and this is knowledge deficit of the staff utilizing the bundle. So this is specifically for healthcare workers. So it can lead to inconsistencies in the delivery of care, and if they're unfamiliar with what it is, they have lack of motivation. Protocol-related barriers, again, know your facilities protocols and procedures, and then staff compliance if they're unaware of like what the benefit is. So communication and care coordination across the multidisciplines. This seems to be very difficult, especially with night shift, because you don't always have all the disciplines present during your shift. Inadequate resources, so staff shortages, lack of equipment with mobility, especially if you don't have ceiling lifts or those mobility devices to actually ambulate your patient. Documentation burden. It's frustrating. It can be inefficient if the staff has low motivation, then documentation falls to the wayside. Patient factors, their instability, communication and barriers, relation to sedation and delirium. And then family discomfort, you might not have family all the time that's fully supportive and participating in their care, and that can lead to resistance towards the staff. However, we want to try our best to push through all those barriers because there are positive outcomes. So doing the ABCDEF bundle is shown to reduce days on the ventilator, prevent vent-associated events, decreases the ICU delirium, and reduces restraint use. It decreases ICU and hospital length of stay, therefore reducing healthcare costs, improve patient outcomes and satisfaction, and improve survival. So according to the Society of Critical Care Medicine in 2023, the implementation of the ABCDEF bundle decreases the likelihood of hospital death within 7 days by 68%. It reduces delirium and coma days by 25%, reduces physical restraint use by more than 60%, and it cuts ICU readmissions in half. It reduces discharge to nursing and rehabilitation facilities by 40%. So since this has been in practice, it has significant improvements in healthcare, in patient outcomes, and improvement for the patients on mechanical vents. So to recap, the bundle consists of A, assess, B, breathing trials, C, choice of sedation or analgesia, D, delirium, E, early mobility and exercise, and F, family engagement and empowerment. Thank you.
Thank you. That was great. Honestly, thank you not for nurses and for respiratory therapists, because if you need this as a physician, good luck.